Welcome everyone to our webinar on the ACO Reach program. I am Amara Rashid and I'm excited to have the opportunity to host the session today. Our focus for the session will be on understanding the key elements for success in the ACO Reach program, including how it differs from DCE and how to prepare for participation. But most importantly, we'll explore the critical role of health equity strategies. By the end of the session, you'll have a much deeper understanding of how to unlock the power of the ACO Reach program to better drive patient outcomes, improve your organization's overall performance, and ensure that your approach is equitable and inclusive for all patients. Before we deep dive into it, there are a couple of things that I'd like to bring to your attention. If you have any questions during the presentation, please type them in the question box in your GoToWebinar control panel. I'll bring them up towards the end of the presentation. Our presenter will answer them for you. We'll send you the slide deck and the webinar recording after the session. Our presenters today are Mr. Gurpinder Singh. He's the technical business analyst at Persivia. Mr. Singh is a tech genius and has a keen analytic acumen. He helps in bridging the needs of our clients with what our platform and tech capabilities can deliver. He's currently working on implementing the ACO Reach program for our various clients. We also have Mr. Faizan Khalid with us, who's also a business analyst, and he's working with Gurpinder to help our clients with the ACO Reach program as well. Now I'll turn the time over to Gurpinder, who will take charge of the presentation and do the rest of the things for us.
Thank you, Mara, for the kind words. All right. Hi, everyone. As Umara mentioned, my name is Gurpinder. I'll be your presenter today, right? If you have any questions, feel free to drop them in the chat. I'll try to address all the questions at the end of the webinar. All right. So the subject that we are talking about is unlocking the power of ACO Reach. Now, as you all know, right, this is the first performance year for the ACO Reach. It's relatively a new program, but it has a lot. We have a lot to talk about it today. So what is the ACO Reach program? The ACO Reach model replaces the current GPDC model that was in place and is designed to advance health equity goals. It put more emphasis on health equity than GPDC and more emphasis on SDOH data as well. Talking about the data generated in the healthcare industry increases by 48% every year. The amount of data produced in 2022 alone exceeded 4 zettabytes. Now, that's the kind of a data it would take to watch 262 million years straight of HD movies. The tsunami of data, along with industry inefficiencies, make healthcare ripe for digital innovation that will enable stakeholders to transform the rich amounts of disparate and siloed patient data into insightful and actionable data across the continuum. And that's where we as Persivia are here to help you out. Moving on to the main goal of ACO Reach. ACO Reach aims at promoting health equity and delivering accountable care in underserved population. ACO Reach requires all participants to create and implement a health equity plan that identifies and delivers care to underserved communities in their patient population. Participants must provide measurable results showing that the health disparities have been reduced through their health equity plan. Second, supporting leadership and governance. Now, the ACO Reach model requires at least 75% of the governing body of each ACO be made up of participating providers or their representatives, and it will require a minimum of 2 advocates for beneficiaries, one from the Medicare, one consumer advocate on the governing body. Third, it aims at promoting beneficiaries with greater participant vetting, monitoring, and transparency. To protect beneficiaries, CMS has increased the vetting process for ACO Reach applicants, and it is doing a robust monitoring of participant progress during the program. The CMS will provide greater transparency about the model's progress and will work to prevent inappropriate coding and risk score growth. As some of you might be aware, it's capped at 3% for ACO Reach. Now, how ACO Reach is different from GPDC. The Reach ACOs must establish a plan for promoting health equity, as we spoke about in the last slide. Now, there will be a health equity beneficiary level risk adjustment for better care delivery and coordination for patients in underserved community. Now, when we talk about the underserved communities, we usually refer to the patients living in uh, the area deprivation index in the top 10 percentile. We'll talk more about it in the upcoming slides. The third one is the ACOs participating in the program need to collect beneficiary reported demographic and social determinants of health, also known as SDOH data, as a key starting point for addressing health equity. SDOH going forward in 2024 will be a mandatory requirement and will start impacting the quality score as well. Now, let's talk about the risk sharing options under ACO Reach. There are two different options, professional and global. A lot of ACOs have opted for professional and some have opted for global as well. In the professional option, you get essentially up to 50% shared savings or losses with the CMS. In the global one, you have the 100% shared savings. Under the professional risk, you only have one option, that is primary care capitation. Now, in the primary care capitation, you essentially get the capitation amount for all the primary care services you are providing, but all the other services will keep going as FFS claims as they're going so far. FFS stands for fee for service claims. Under the global one, you get both the options, the primary care capitation and the total care capitation. The key point in ACO Reach that we need to notice is CMS has introduced the claims reduction. For the performance year 2023, the claims reduction are set at for primary care capitation at between 10 to 100%. For next year, it's going to be 20 to 100%, and going forward, it will be 100%. However, for the total care capitation, the claims reduction are at 100% starting from this year. There is another program known as advanced payment option. It usually complements the primary care capitation. So as we spoke about, the primary care capitation and the FFS claims. Under APO, it complements uh, the primary care capitation, and you can choose for APO on your FFS claims as well. We might be discussing more about it in our upcoming webinars. Now, the key question, what is health equity? Now, health equity is to ensure everyone has a fair and just opportunity to attain the highest level of health. The CMS has been focusing on it more than ever before. It is aimed at making efforts to address avoidable inequalities, historical injustices, and social determinants of health. The goal is to eliminate all the disparities in healthcare. It is to ensure all the people across US are getting the best possible healthcare services. Now, talking about advancing health equity, the role of data interoperability and care coordination. Data quality and interoperability will be the key to complying with the health equity goals for this program. They will focus on identifying and supporting underserved patients in their beneficiary population. Second, collecting and sharing data. SGS across the care network will help ACOs to develop meaningful outreach campaigns and risk mitigation strategies that can address things like language barriers, health insurance, and cost of care. Also including the transportation to medical appointments, housing insecurity, dietary support, and medication access. These data feeds should integrate into existing EHR records and health IT systems with the goal of seamless data exchange across the continuum of care. This ensures that throughout the care network, providers can collaborate to support social as well as clinical needs of the patients. Now, improved care coordination can help ACOs to reduce avoidable utilization, ensure safer care transitions, and create better health outcomes for the patients. Implementing an encounter notification system with customized actionable clinical data feeds that can notify care teams when their patients are hospitalized, transferred, or discharged, can ensure that providers know what is happening with their patients in real time to prevent the gaps in healthcare. Moving on, considerations for the organization looking to succeed in ACO Reach. There are two things. One, to maximize the revenue. Second, to maximize the shared savings. To maximize the revenue, we can use the retention of the beneficiaries and what we call it beneficiary engagement tactic that support retention, processes to support maximize quality scores. Now, we will talk about more about maximizing the revenues, shared savings, the benchmarks going forward in this presentation. Now, the key factors for revenue optimization. One of the key factors is to understand the benchmark. What are the different benchmark calculation factors? What are the different factors that CMS has introduced? Now, we'll talk about how the benchmark is calculated, but there are different adjustment factors as well that we should take a look at. One of them is retention withhold. Retention withhold is at 2% of the total amount of care or the benchmark. Now, the retention withhold, the CMS will release the retention as soon as we sign up for the second year as an ACO. There is also a 2% quality withhold that we'll be discussing in more detail going forward. Now, something new has been introduced in the ACO Reach. It's known as the HEBA adjustment or the Health Equity Benchmark Adjustment. As we, as we spoke about, the patients or the beneficiaries who should be getting the the same kind of care across the states. So the people who are living in a top 10% of area deprivation index, they will be covered in this. We'll cover this as well going forward. Now, talking about the four different matrices. First, the beneficiary alignment. Under ACO Reach, there are two different types of beneficiary alignment. One is the claim-based, second is voluntary alignment. Claim-based alignments are simply the beneficiaries for which the providers have been filing claims in the past. They are automatically aligned as the claims-based beneficiaries. The voluntary alignment is simply if a patient has signed to be your beneficiary, they will come under the voluntary based alignment. And this is going to play a key role. And how it's going to play a key role, we'll be talking about that as well. Now, the care management. This is to ensure that we deliver the extended Medicare benefits to disadvantaged communities. How we can do that? More active involvement in their treatment, enhanced benefits like telemedicines, remote patient monitoring systems, post-clinical home visits, and decreased cost sharing. The beneficiary engagement. Now, the beneficiary engagement, a powerful engagement strategy that starts with access. Access is the first step to understand and with aligning on the treatment plans. While in-person appointments may be necessary for certain visits, a growing number of Medicare beneficiaries use and prefer digital communications. Unfortunately, even forward-thinking MA plans under-deliver on these digital tools, likely to widespread, often mistakes, and again stereotype that older patients can't effectively use technology. Two of the most powerful digital tools are telehealth and patient portals. These tools are especially effective in care management. Once beneficiaries have access to care, their next step is to enhance engagement. Engagement takes many forms, but things on proactive outreach, reminding beneficiaries of important health screenings, sharing new tools to manage their care, and even closing care gaps using the patient-reported data all are effective engagement strategies. Once beneficiaries are engaged, providers should offer educational resources, especially for the beneficiaries with chronic or complex conditions. Using an evidence-based protocol for diabetic patients, beneficiaries can better understand and therefore better manage the condition. Moving on to the benchmark calculation factors. How do we calculate the benchmark? There are different factors. As we all know, for the performance year 2023, CMS has provided us with the benchmark numbers based upon the beneficiaries that we have under our ACOs. But going forward in 2024, the benchmark will be calculated based upon these factors. First, the total eligible months. Total eligible months is nothing but the number of beneficiaries you have multiplied by average alignment in a year. So if you have 10 beneficiaries aligned for on an average 7 months per beneficiary, you have 70 eligible months. The second factor is historical baseline expenditure. For the historical baseline expenditure under ACO Reach, the reference years are 2017, 2018, and 2019 with the weightage of 10 ratio 30 ratio 60 respectively. So the reference year 2019 will have 60% weightage while calculating the historical baseline expenditure. There are some other factors as well, like a prospective trend, ACO's normalized risk score, geographically adjusted factor, which talks about the area in which your beneficiaries are. All these factors combined calculate the historical baseline. Now, apart from this baseline, we also get the regional rate based upon the ACO Reach. This is a document that has been shared by the CMS. It's available on the ACO Reach page of the CMS website. All this data is used to calculate the blended benchmark. Now, important thing to note here is all these benchmark calculation factors come in effect if you are a standard entrant in the ACO Reach. However, if you are a high risk entrant or a new entrant, if you are a new entrant, you don't have the beneficiaries. Thus, we cannot calculate the total eligible months. So for the new entrants and the high risk ACOs, the benchmark will be calculated only based upon the regional rate book or the KCC rate book. Now, talking about the uh, health equity benchmark adjustment. Now, we have spoken about it so much, right? So what is the financial impact of the health equity benchmark on the ACO Reach? So what CMS is offering us that if you serve the population that belongs in top 10 percentile of the area deprivation, they provide us with an additional $30 per beneficiary per month, and they add it to our benchmark. So essentially for each beneficiary that we have in the area deprivation index, we receive $360 per year and as an additional amount. However, if we are serving the population that belongs in the top 50 percentile of the area deprivation list, we lose $6 per beneficiary per month as well. And if our population belongs in the 50 to 90th percentile of area deprivation, there is no change in the benchmark amount. Now, for beneficiaries to be under the health equity benchmark or to be part of this, there are two conditions. They should have dual eligibility status at beneficiary month level. And second, as we spoke about, is the area deprivation index. Now, this is a deeper topic, right? So if you have any questions specifically regarding the health equity benchmark, please feel free to reach out to us. You can reach out to me and we can discuss in more detail later on. Moving on to the health equity data reporting adjustment, or what we call it HEDR. Now, CMS is requiring all the ACO Reach ACOs that are involved in REACH program to collect and submit the data to CMS. These include the beneficiary reported demographic data. We'll take a look at all the components in the next slide, but for the year 2023, SGUH data has no impact and reporting is optional. However, going forward in the performance year 2024, it's going to be a mandatory requirement. Now, how Persivia can help you do this is Persivia can create a longitudinal record merging data from EHRs, HIEs that are Health Information Exchange, the claim files, and other sources. The HEDR components that we need to capture include the member beneficiary ID that will be provided by the CMS, beneficiary first name, last name, and also if you are already the existing members of ACO Reach, you would have received the first set of claim files that does include some of this data. Other data include date of birth, sex assigned at birth, preferred language, beneficiary race, and ethnicity. The sexual orientation and gender identity are not required for performance year 2023, but they are a requirement going forward from year 2024. Another factor, the quality withhold. There are two different types of measures. One are claim-based measures, and second is patient experience measures. Now, the patient experience measures, some of you might already be familiar with. It's called CEHPS survey. That is Consumer Assessment of Healthcare Providers and System Survey. For the claim-based measures, there are four different quality measures. Now, depending upon if you are a standard entrant and a new entrant, the only three measures that you need to worry about for the claims-based are the risk standardizations, all condition readmission, all cause unplanned admissions for patients with multiple chronic conditions, and timely follow-up after acute exacerbations of chronic conditions. However, if you are a high needs ACO, you also need to take care of the fourth quality measure, that is days at home for patients with complex chronic conditions. The Persivia, how Persivia can help you with this, we have our own quality portal where you can keep track of each of these quality measures. You can see which patient belongs to the numerators, and if you need to take any actions that we need to perform on that. The quality withhold just not have 2% impact on the total amount. It also has an additional impact, something we call as high performers pool in the ACO Reach. Now, under the high performers pool, the Reach ACOs that meet the CISCP criteria and have average percentile rank of greater than 70% will be provided with additional amount. Now, this additional amount will be collected from collaboratively from all the ACOs that are losing money on the quality. All that amount will be clubbed together and distributed proportionally to all the eligible Reach ACOs which belong to the high performers pool. Thus, quality score has a lot more impact in the ACO Reach than just 2%. Going on to the steps to ensure the ACO Reach success. First and the foremost, the key point is to identify the ACO Reach patients. You might be serving a population of 100,000 and there might be maybe like 7,000, 8,000 beneficiaries who are eligible for ACO Reach. The first step is to identify the ACO Reach patients based upon the eligibility criteria shared by the CMS. Once we have identified, we need to make sure that we are tracking the real-time progress of these patients and care opportunities. The third one is to reduce the beneficiary leakage to minimum. The beneficiary leakage can simply be reduced if we are keeping them as our beneficiary, be that a claim-based beneficiary or a voluntary line beneficiary. The fourth point, increasing the benchmark. As we discussed in the previous slides, right? How can we increase the benchmark? If we have more beneficiaries, if we have more beneficiaries lying in the health equity benchmark adjustment, right? That contributes to $360 per beneficiary per year. If we have beneficiaries in the low geographically affected score, as we spoke about in the benchmark calculations, if we have beneficiaries with high risk score. So all these factors contribute to increasing the benchmark. And how can we reduce the expenditure? We can reduce the expenditure by making sure we are doing the timely follow-ups. Now that is a quality measure, as well as it's helping us to keep the expenses to minimum. Now, another benefit of the ACO Reach program, and the reason we didn't cover it, is everybody is familiar with this capitation amount, right? So ACO Reach is a population-based program where it's based upon the capitation. So the capitation amount is to ensure that we are getting the capitation money to build resources for the better care of our patients. Moving on to the next slide. That is fueling the most powerful and extensible population health platform, what we call is CareSpace. Persivia provides organizations with a patient-centric view of critical and actionable information to improve clinical, financial, and operational performance by identifying clinical interventions and segmenting patient populations. We help in streamlining organizational workflows, mitigate risks, and improve the quality of care for patients, all while managing the total cost of care. The solution combines cross-organizational workflows, deep analytics, multiple risk stratification algorithms, and an integrated longitudinal record comprising EHR, HL7, claims, SUS data, and patient-reported data. The solution allows clients to identify and track high-risk patients and uncover those with the high-risk data with the most actionable improvement opportunities. The company's innovative capabilities fall into the following categories. One, the care management systems allow clinical staff to provide long-term care services to patients while helping the practices convert administrative patient interactions to clinically relevant and billable encounters that not only improve the care and quality but also increase the revenue. Second, we provide the real-time alerts, reports, analytics, and notifications for both the care providers and the patients. The Our quality management analytics and reporting for both hospitals and ambulatory providers ensure that we are on par as far as the quality is concerned. The cost and resource management analytics to support MIPS and APMs, including the PPCI, BPCI Advanced, ACO, Primary Care First, payment information initiatives. We also have a cloud-based web service and HL7V 3.0 based IT infrastructure and applications that deliver these capabilities to healthcare systems. Persivia has an extensive experience developing and deploying the population health management solutions that integrate into the hospital systems, EHRs, and state and federal health agencies. Moving on, how Persivia can help, or I would rather say how Persivia is helping our existing clients. Persivia provides an end-to-end solution. Persivia has an extensive experience with providing comprehensive AI-driven analytics. And for the ACO Reach specifically, what we can do for you is we have an eligibility algorithm in place. Once we have the population under your ACO, we can run our eligibility algorithm, figure out in the matter of minutes, if not hours, that which of these patients are eligible for ACO Reach. Once we have the patients who are eligible for ACO Reach, we have a clinical program in place. Now, the clinical program is focused on complete care coordination of the patients. Ensure all the care gaps are generated in a timely manner. These all care gaps can be administered and closed by the providers or by the care managers. We also provide the care gaps for PCP services, readmissions, all the quality score care gaps. We spoke about how big impact the quality score also plays. We can create care gaps so we can address all the quality measures before they start to negatively impact our system. We also have a claims-based program. Now, the claims-based program provides a bird's eye view on all the analytics and the financials. Not only that, we also have a system in place for the HCC claims opportunities. Now, these HCC claim opportunities provide you opportunities at a beneficiary or a patient level. You can monitor these opportunities, close the opportunities in the system, make the interactions. All this is done using the AI engine that we have. We spoke about the claims HCC opportunities. We do also have a clinical HCC opportunities in place that covers risk stratification, risk adjustment, and pretty much everything that you need to make ACO Reach a success. So combined with all four catalogs being the eligibility, clinical program, the claims program, and the quality program, we ensure ACO Reach is success for your organization as we are doing for our existing clients. Talking about our portfolio, we have hundreds of customers who already rely on Persivia, and we have been providing them the reliable services from years. We have 3 state DPHs, 7 EHR integrations, 19 payers who have been sending us data, more than 200 hospitals, more than 800 SNFs, couple thousand labs, and 35,000 physicians who trust us with our system. These are our three key relationships that we have. McLaren Healthcare, they're based out of Michigan. Prime Healthcare, they're one of the largest for-profit organizations across United States, and then the USMM. That's how we can help you be a success in ACO Reach. We will be open to the questions now.
Thank you, Gurpinder. We'll go ahead and take some time for the questions now. Just a reminder, everyone, please be sure to type your questions into the question box in your control panel. So at this point in time, it looks like we have a couple of questions at hand. So I'll start with the first question that pops up. It says, can a patient be both a BPCI and ACO Reach patient?
That's a really good question, Umara. So CMS has provided us with the preference list. So the simple answer is no. The ACO Reach program will trump the BPCI or CGR program in that fact. And the beneficiary will be a ACO Reach beneficiary, and he will no longer be a BPCI beneficiary. However, if you need more details, we can have a separate discussion on this one.
Okay, great. So should I move on to the next question?
Yes, Umara, please.
Okay, so there's another question that says that how do we ensure beneficiary alignment?
All right. So to talk about this, we need to take a step back here. So there are two different types of beneficiary alignment in the ACO Reach program. One is the voluntary alignment, one is the claims-based alignment. For the voluntary alignment, we simply have to get the alignment form signed by the beneficiary. For the claims-based alignment, there is a simple rule. We need to ensure that we are filing one claim for that beneficiary in the last 9 months. Now, that can be an annual wellness visit claim, that can be a PCP service claim if you're opting for primary care capitation. If you're opting for a total care capitation, it can be any claim within last 9 months. That's a simple rule. And as a matter of fact, Umara, I'm glad you brought this up. We already have this care gap in place where we let the ACO know if they are about to lose an alignment for a beneficiary. If the beneficiary has not, a claim has not been filed for a beneficiary in last 6 months, we notify the care managers and we tell them that we have a quarter, otherwise we might lose this beneficiary alignment.
Okay, that's great. So I see another question here. How do I see how many of my beneficiaries are part of the underserved community?
So for this question, how many beneficiaries are part of underserved community, right? Okay, so the rule of thumb here is that your patient should belong in the top 10 percentile of area deprivation index. Now, how we can do that is in CMS has provided us with a link. It's a Wisconsin University link. I think if we are able to share that in chat, we can do that, or I can share that in the chat. And it's a very simple link. You can just go there, enter the address of your beneficiary, and you'll get to know that under what ADI do they lie. And if you want an extensive report on that, we can always help you out with that.
All right. Okay, so it seems we have covered all the questions for now. If there are more questions from your end, you guys can send us in the email as well. So Gurpinder, is there anything else that you wanted to add to cover before I wrap up here?
The only thing I would like to add here is this is not all that we we try to cover as much stuff as we could in this webinar, but we'll have maybe 1 or 2 more sessions on the ACO Reach. So stay tuned with us. And if you have any questions, don't wait for the future webinars. You can reach out to Umara, you can reach out to me directly, you can reach out to us on our website, and we'll be more than happy to help you guys.
That's very helpful, Gurpinder. So thank you, everyone. We appreciate you being here. We're going to email you the webinar slides and the recording in the next 24 hours. And hopefully you'll find it useful. We'll see you next time. Have a great rest of the day. And just a reminder that if you have any questions, you can, if you have more questions related to this event, you can send them in the recording email. You can reply to the recording email you'll be getting in the next day or so. Thank you, everyone. Thanks. Bye-bye.